So, here is a quick thought experiment for you to kick things off today.
Okay.
Think about this. If you walk into a Starbucks in Seattle,
Right.
and then you fly halfway around the world, and you walk into a Starbucks in Tokyo or Johannesburg or Buenos Aires, you expect the coffee to taste pretty much exactly the same, right?
Yeah, that's the brand promise. I mean, consistency. You know exactly what you're getting.
Exactly. And we tend to apply that exact same logic to modern medicine.
Subconsciously, at least.
Right. We operate on this assumption that a standard of care is, well, standard.
Mm-hmm.
If you break your leg, an X-ray is an X-ray. If you have chest pain, a heart scan is a heart scan. The physics of the machine shouldn't change just because you crossed a border.
It's a very comforting assumption. We really want to believe that medical technology is this universal constant, that the machine does the exact same thing regardless of the zip code or, the flag flying outside the hospital.
But for today's deep dive, we have a stack of research on the desk that completely shatters that assumption,
It really does.
specifically regarding our hearts. And honestly, it's a little unsettling.
It is unsettling. We're looking at a hidden variable in heart health that most patients and probably most doctors never even think to ask about.
Radiation.
Radiation.
Right.
We are diving into a massive new cross-sectional study. This was published in JAMA.
Journal of the American Medical Association.
Right, from February 2026. And the headline finding here is that if you need a diagnostic test for coronary artery disease, the amount of radiation you absorb isn't just determined by your biology.
No.
It's determined by your geography.
And the variance we're talking about isn't small.
No.
We aren't talking about a 5 or 10% difference here. We are seeing massive structural disparities where the exact same test can deliver multiples of the radiation dose simply depending on where the hospital is located.
It's what we're calling the hidden variance. So the
Yes.
mission for this deep dive is to unpack this study for you.
Yeah.
We need to understand the menu of modalities, basically what these tests actually are.
And then figure out why a patient in one country might get a safe, perfectly optimized scan, while a patient in another country gets blasted with a dose that's 20 times higher.
And ultimately, we need to talk about what that means for global health equity. Because this is a story about technology, sure, but it's really a story about infrastructure and access.
Absolutely. Now, before we get into the scary numbers, and there are some genuinely scary numbers coming up,
Definitely.
let's establish the credibility of the source. Because sometimes you read these studies and they're small, right? Like a few hundred people in one single city.
Yeah, that is not what this is. This is a heavy hitter.
Just massive.
This study involved 19,302 adults.
Nearly 20,000 people.
Right. And they gathered data from 742 different medical centers
Wow.
across 101 countries. And what I really love about their methodology is that they did it all during a single snapshot week.
Right, between October and December of 2023.
Exactly.
So it completely eliminates the time variable.
Yes.
This isn't comparing, say, old data from 2010 to brand new data from 2023. This is asking what happened in heart clinics all over the world during the exact same week.
Precisely. It gives us a real-time look at the global state of cardiac imaging. It's like taking the pulse of the entire planet's radiology departments all at once.
Okay, so let's get into the meat of it. Section 1, the menu.
Okay.
The study focused on non-invasive testing for coronary artery disease, or CAD. Now, as usual, medicine loves its acronyms.
It really does.
We have SPECT, PEAT, CAS-CS, and CCTA. I feel like we need a quick glossary for you listening at home before we can even parse the data, because otherwise it's just alphabet soup.
Fair enough. It can get very confusing. Let's break them down into two main families.
Okay.
You have the nuclear family and you have the CT family.
Let's start with nuclear, just because that sounds the most intense.
It sounds intense, but it's actually very common. So this covers SPECT and PEAT.
Okay.
SPECT stands for single photon emission computed tomography, and PT is positron emission tomography.
Yeah, I'm going to need the explain like I'm 5 version of that, please.
Sure. Essentially, for both of these, the doctor injects a very small amount of a radioactive tracer in your bloodstream.
Okay.
That tracer emits gamma rays or positrons. Then, a specialized camera either rotates around you or sits stationary and detects those emissions to create a map.
A map of exactly.
A map of blood flow to your heart muscle. It shows you where the blood is going, and more importantly, where it isn't going.
Oh, I see. So if there's a dark spot on the map, that means blood isn't getting there, which means
A blockage.
a blockage. Got it.
Exactly. It's a functional test. It shows how the heart is actually working in real time.
Okay, so that's the nuclear family, injecting a tracer and watching it flow. Then we have the CT family.
Right. computed tomography.
Right.
This uses X-rays, not injected radioactive tracers. Well, mostly. The first one here is CACS.
Which is the calcium score, right?
Exactly, the calcium score. This is the simplest one. It's a very quick scan looking specifically for calcified plaque in the arteries.
Like a check engine light?
That's a great way to put it, a check engine light. Doesn't show you the blood flow, it just shows you if there is hardened gunk in the pipes.
And the last one, CCTA.
Coronary computed tomography angiography.
That's a mouthful.
It is. This is the heavy lifter of the group. It's a CT scan, but they inject an iodine contrast dye.
Not a radioactive dye.
Right, not radioactive,
Yeah.
just opaque to X-rays. This allows the scanner to build a high-resolution 3D model of the blood vessels themselves.
Oh, wow.
It's anatomical. You can see the narrowing of the artery in incredible detail, almost like you're flying through the vessel.
Okay, so just to recap, calcium score is a quick check. CCTA is the detailed 3D roadmap.
Correct.
Now, the study measured the effective dose of radiation for all of these different tests. And in the radiation world, we measure that risk in millisieverts.
Millisieverts or MSV, yes.
They are the currency of radiation risk.
Exactly.
So let's set a baseline. If I want the safest test possible, purely from a radiation standpoint, what's my winner?
The calcium score.
Yeah.
Hands down. The global median dose for that was just 1.2 millisv.
1.2. Is that a lot? It's hard to visualize.
For context, the average person absorbs about 3 millisv per year just from background radiation.
Like from the sun.
The sun, the earth, the radon in your basement, just existing.
Right.
So 1.2 is very low. It's roughly a third of what you get just by living on Earth for a year.
Okay, so that's the gold standard for safety. What about the nuclear options?
They're surprisingly efficient, actually. PET scans came in with a median of 2.0 millisv.
Really? That is surprising.
Right.
You hear the word nuclear and you automatically assume it's going to be glowing green and setting off Geiger counters.
Well, PET technology has gotten very good, very sensitive over the years.
But
But then we have the other nuclear option, SETS-PCT. That median jumps up to 6.5 millisv.
oh, that is a significant leap. We've gone from 2 to 6.5.
And then we have the CCTA, the detailed 3D angiography. The median there was 7.4 millisv.
Okay, so broadly speaking, the detailed angiography and the SPECI scans are delivering roughly 3 to 6 times the radiation of the simpler tests.
On average, yes. But averages can be incredibly deceiving.
How so?
The study looked at the interquartile range, basically the spread of the data across all these centers.
Right.
And for CCTA, that spread is massive. The upper end of that range went all the way up to 15.5 millisv.
Wait, so you could walk into one clinic and get 7, or you could walk into another and get 15?
Exactly.
And you, as the patient, have absolutely no way of knowing which one it's going to be.
You don't. And 15 is concerning. The medical community generally agrees on a benchmark of less than or equal to 9 millisv as the target for these tests.
So 9 is the safety benchmark, the optimized zone.
Right.
If 9 is the target, how are we doing globally? Like, are most clinics hitting that?
Not great. And this was a twist I really didn't expect.
What's the twist?
Well, you'd think the fancy high-tech CT scans would be the most controlled, right? Because they are newer technology. But actually, the nuclear cardiology centers are way more disciplined. The study found that 81% of centers performing nuclear tests hit that safety target of 9.
Okay, 81%. And the CT angiography centers?
Only 56%.
Wow.
Yeah,
So it's basically a coin flip.
it is.
If you go in for a CCTA today, there's a nearly 50% chance you are getting a dose higher than the recommended safety limit.
Globally, yes, it's a coin flip. But, and here's where the study completely pivots,
Okay.
that coin is weighted. It is weighted heavily by where you happen to live.
This is the geography is destiny section.
Yes.
This is what really grabbed me when I was reading the report. Because we aren't just seeing random variations here, right? We are seeing strict patterns.
Very distinct patterns.
Yeah.
The study broke the data down by region, and the disparities are frankly stark.
Let's look at the winners first. Who is optimizing this the best? Who's hitting that bullseye consistently?
Western Europe. Across the board, they are the gold standard.
Okay.
For nuclear cardiology, their median dose was roughly 4.8 millisv, and for CCTA, it was 4.6 millisv.
4.6. So they are consistently coming in at basically half the safe limit of 9.
Exactly. If you get a heart scan in Berlin or Paris or London, you are highly likely to get a highly optimized low-dose procedure.
Because they have stricter regulations?
Strict regulations, generally newer equipment, highly trained staff, yes.
Now, contrast that. Where are the outliers? Where are the doses spiking?
Well, it depends on the modality.
Yeah.
For nuclear cardiology, Latin America had the highest median dose at 7.8 millisv.
7.8. Okay, higher than Europe, certainly, but perhaps not catastrophic. It's still under that 9 millisV benchmark on average.
Right. But then we look at CCTA.
The 3D scans.
Yes. And we look at Africa.
Oh, boy.
This statistic actually stopped me in my tracks.
Honestly, I thought it was a typo in the abstract. I literally highlighted it and wrote, check this, in the margin of my notes.
It's not a typo.
Yeah.
The median effective dose for CCTA in Africa was 25.2 millisV.
25.2?
Yes.
Wait, just for one test.
For a single diagnostic image.
That is staggering.
Let's put that in perspective for a second. Western Europe is at 4.6.
Right.
Africa's at 25.2. That is more than 5 times the radiation for the exact same diagnostic image.
And compare it to the calcium score baseline we talked about earlier. That was 1.2.
Exactly.
A patient in Africa undergoing CCTA is receiving 20 times the radiation exposure of a simple scan.
It changes the risk profile completely.
It has to.
At 4 mSv, the risk of inducing a future cancer is basically negligible. It's background noise.
Bet 25.
At 25 mSv, it's still statistically low for any one individual, but it's no longer negligible. It is a significant biological hit.
That is absolutely massive. We aren't talking about a tiny margin of error here. We aren't talking about a 10% fluctuation. We are talking about multiples.
Multiples. And that fundamentally changes the calculus of do no harm in medicine.
So the obvious question has to be why? Why is there such a massive gap? Is this just negligence? Is it a lack of care?
No. And the study is very, very clear on this. It is not malice. It's not that doctors in Africa or Latin America don't care about their patients. It's entirely about economics and infrastructure.
Right.
The authors actually ran a regression model matching the radiation doses against the income levels of the countries.
And I assume it's a straight line.
A very steep one. It's an inverse relationship. As the country's income level drops, the patient's radiation dose rises.
Let's put some solid numbers on that gap to solidify it.
Sure. So for nuclear cardiology, low and middle income countries, what they call LMICs,
Okay.
they had doses about 20% higher than high income countries.
Significant. But the gap for CCTA must be way wider, given that Africa stat.
Much wider.
Yeah.
For CTTA, LMICs saw doses up to 96% higher than high income countries.
So basically double the radiation.
Double the radiation on average, purely based on the economic status of the nation you're standing in.
Help us understand the mechanics of that. Why does a poorer country equal higher radiation? Is it just older machines?
That is a huge part of it. Think about how fast technology moves. A state-of-the-art CT scanner today has incredible software built in.
Like AI and things like that.
Exactly. Uses AI to position the patient. It modulates the tube, current, basically the power of the X-ray beam, in real time, adjusting for the patient's exact body size as it scans.
Oh, that's smart.
It creates a perfect image with just a whisper of radiation.
And an older machine.
An older machine, say one that's 10 or 15 years old, is a blunt instrument by comparison. It doesn't have that modulation.
So it's just on or off.
Pretty much. And to ensure they get a clear picture, because a grainy picture is completely useless for a diagnosis, they have to turn the power up. They have to blast the patient to guarantee the image comes out clear.
It's like using a massive floodlight instead of a laser pointer.
Yes.
Or, like trying to take a photo in a dark room with an old disposable camera versus a new smartphone. The old camera needs this massive flash to get anything at all.
That's a really great analogy.
Yeah.
And high-income countries replace their scanners every few years.
Right.
In lower-income settings, a hospital might buy a refurbished scanner that was already used in Europe for 5 years.
And then they use it for another 10.
Exactly.
So the recycling of the high-income world basically becomes the medical standard of the low-income world.
Harshly put, but unfortunately often true. But it's not just the hardware. That's the thing. It's also the software of the humans running it.
You mean the protocols they follow?
Right. There are sophisticated techniques to lower doses even on older machines. One is called prospective ECG gating.
Perspective gating. Unpack that for us.
Basically, you sync the scanner to the patient's heartbeat. You hook them up to an ECG.
Okay.
The machine waits, and it only turns the X-ray beam on for the split second when the heart is perfectly still, right between beats.
Oh, wow. So you aren't radiating them the whole time the machine is spinning.
Exactly. It cuts the dose dramatically because the beam is literally off for most of the cycle.
That's brilliant.
It is, but doing that requires training. It requires a lot of confidence. It requires a machine that you trust can handle it. If you are a technician who maybe hasn't been trained on the latest protocols, or you're worried your older machine is just too slow to catch that specific beat, what do?
You just leave the beam on.
You leave it on. You use what's called retrospective gating. You scan the whole cycle just to be safe. It guarantees a good picture, but it triples or quadruples the radiation dose.
That is really the tragedy of this. It's a safety mechanism trying to ensure a good image so you don't miss a heart attack that actually causes a totally different kind of harm.
And we really have to remember who is on the table here. The study noted the demographics. The median age was 63. 44% were female.
Right.
These are people who are already vulnerable. They are scared. They have chest pain. They trust the white coat.
They aren't experts.
Exactly. They don't know to ask, hey, are you using perspective gating? Or is this a 64-slice scanner?
They just want to know if they're going to have a heart attack next week.
Right. And they are paying a hidden a radiation tax for that answer.
But there is a nuance here that I actually found really hopeful when I read this study.
Oh.
Yeah, it wasn't purely a rich country, poor country split. The data wasn't just two neat blobs on a graph.
No, it wasn't monolithic at all. They found marked variation even within regions and within income levels.
So you could have two hospitals in the exact same middle-income country with totally different outcomes.
Yes, absolutely.
Okay.
You might have one hospital in Brazil or India that is running perfectly optimized protocols, hitting that 4 millisV target.
Right.
While the hospital down the road in the same city is at 15 millisV.
And what does that tell us? Like, why is that hopeful?
It tells us that we don't have to wait for global economic equality to fix this problem. We don't need to buy every single hospital in Africa a brand new $1 million scanner tomorrow to make a dent.
You can improve the human software.
Exactly. Training, standardization, better adherence to guidelines.
Yeah.
If we can get technicians in these high-dose centers to just trust the lower-dose protocols, to use the modulation tools they do have,
We could likely cut that radiation gap in half without spending a fortune on new hardware.
it's just low-hanging fruit.
It really is.
It's knowledge transfer. And that is so much cheaper and so much faster than hardware transfer.
Let me ask you this. Why is this hitting the radar now? I mean, radiation has always been bad, right? Why is this a hair-on-fire moment for the medical community in 2026?
Because the volume of these tests is just increasing exponentially. Rates of coronary artery disease are skyrocketing globally.
Because populations are aging.
Aging populations, lifestyles are changing, diets are changing. We aren't doing fewer of these diagnostic tests. We are doing millions more every single year.
So the cumulative burden is stacking up.
Right. If one person gets a high dose, that's a data point. It's unfortunate, but it's a data point.
Yeah.
But if 10 million people get unnecessary excess radiation over the course of a decade, that is a massive public health crisis. That translates into a measurable increase in cancer rates 20 years down the line.
So efficiency here isn't just about saving money or saving time for the hospital. It's about long-term population safety.
Absolutely. We have to look at the aggregate harm.
So let's try to bring this all together. We have this miracle technology. We can peer inside the human heart, we can see the blockages, and we can save lives without making a single incision.
It is a marvel. And we really shouldn't lose sight of that. It has completely revolutionized cardiology.
But the cost of that miracle, the physical toll it takes, is distributed incredibly unevenly.
Yes.
If you are in Western Europe, the cost to your body is low. If you are in Africa or parts of Latin America, the cost is significantly, sometimes dangerously higher.
And the proof that it can be lower is right there in the European data. We know exactly how to do this. The challenge isn't invention anymore, it's distribution.
Right.
It's about democratizing the safety protocols, not just the physical machines.
It feels like such a clear, obvious target for organizations like the WHO or global cardiology societies. I mean, it's not like trying to cure a mysterious new virus. It's literally just tuning the dials on the machines we already have.
It's an actionable problem. And honestly, those are the best kind. You can measure the problem, you can fix it, and you can immediately measure the improvement.
I want to leave everyone listening with a thought that's been kind of nagging me since I first read this study.
What's that?
Well, we've spent this entire deep dive talking about heart scans.
Right.
But medicine is full of standardized tests. CT scans for lungs, scans for brains, routine x-rays for broken bones.
Ah, I see where you're going.
If it's happening here with hearts, where else is it happening?
Exactly.
If a standard diagnostic test for the heart can vary in radiation intensity by 500% or over 2,000% if we compare the absolute extremes, depending purely on where you live.
What other standard procedures have these massive hidden variances that we aren't tracking yet?
Right. It's a very provocative question. We assume medicine is this hard science, fixed and immutable.
But medicine is practiced by humans. It's practiced within totally different economies, using machines bought by different hospital budgets. It is incredibly variable.
And for you as a patient, it's deeply frustrating. Because what do you do with this information? You can't exactly audit the hospital's equipment while you're lying on the gurney with active chest pain.
No, you can't. And this isn't a problem that patients can solve just by asking better questions. This is a problem the global medical community has to solve for them. The question isn't what should the patient do?
Right.
The real question is, why should your geography determine your safety?
That is the question. The
Well,
study is called Global Radiation Trends in Coronary Artery Disease Diagnostic Imaging, published in JAMA, February 2026. It's a dense read, but a really crucial one.
highly recommended. It's vital data.
Thanks for helping us break it down today.
Always a pleasure to dig into the numbers with you.
And thank you for listening. Keep asking questions, even the uncomfortable ones. And we'll see you on the next Deep Dive.